Good morning to all. We go on to the next session, which is cancer genomics and precision medicine in cancer care, unraveling its full potential, especially with a focus on Kerala. This session will focus on the impact it has had in our clinical care and also how we can impactfully deliver it in our current society. I would like to welcome our moderator for the session, Dr. Sevanthi Limaye, whom we know as a leading precision oncologist at HN Reliance Center. Madam is also the in charge of the translational oncology research over there. She has more than 2+ decades of experience, clinical experience in oncology. She has written, Dana-Farber, Columbia University, a lot of experience there, and then has come back to our country and is working there at the moment. I would also like to welcome my panelists. We have esteemed set of panelists. I would like to start with Dr. Ramesh Hariharan, who is also the CEO and founder of Strand Life Sciences. Sir, please come ahead. We have, he is also an adjunct professor in the IIT, Indian Institute of Sciences. Dr. Sam Santosh is a major entrepreneur, a major player and founder of MedGenome. I think a lot of us in this sitting here have seen the impact of his work. Sir, please come ahead. MedGenome, AgriGenome, a lot of companies are there. I would also like to involve Dr. Amol Akhade, who has had a lot of impact in teaching our medical oncologists a lot of data. He is a community oncologist with more than 2+ decades experience. Please take a seat. In Suyok Cancer Center in Mumbai, where he is the lead. I would also like to welcome Dr. Suruchi Agarwal. She is somebody we have interacted with in the past. She is right now serving as the Associate Director of Strand Life Sciences. She is a genomist. Also, she has genetic counseling, PhD also in genetic counseling, a very impactful area. And I would like to welcome Dr. Prashant Ganeshan, sir, Professor, Jipwar Medical Oncology. He has more than 2 years plus experience, 2 decades plus experience in oncology, and he has also been in institutes throughout his career and will give a perspective from that. Without much ado, ma'am, I'll hand over the session to you.
Thank you so much, Dr. Nikhil, for all the hard work and the coordination to bring us all here together. And huge thank you to the Kerala Cancer Conclave organizers and dear friend Aju for inviting me to moderate this session. It's a true honor and privilege to be standing here today to moderate this session. And amazing session, the last one. We saw the banter at the end and great moderation to follow in footsteps of Kuriakos sir. That was amazing. Now we have 2 of us, myself and Amol, have to catch the 1:35 flight. So we have a hard stop at 12 o'clock and we are going to go rapid fire with all the questions that we have collected. So first of all, a very warm welcome to all panelists. It's a great opportunity and privilege for me to have you here sitting as my panel to help go through some interesting topics and questions, some of them very, very controversial. Considering I'm standing here, a lot of the people in the crowd may be able to make sense of what I'm saying, and Amol will certainly understand what I'm saying. So, we talk what's standard of care, we talk beyond standard of care, we talk what's game, what's not game, and we deliberate on the hot topic, genomics and precision medicine in cancer care. Okay, so I say the view from India because, a lot has been said about precision medicine abroad. It is, I was just going through opinion pieces that have been published in the recent times from Indian authors regarding precision medicine, precision oncology, and essentially everywhere it said, India is yet to arrive in precision oncology. So with that, I would like to open our panel discussion to see how we take this forward and what is our view from India. And of course, we are graced by none other than Dr. Suresh Advani sir here, who is godfather of oncology and truly would be able to, I would like to get your insights as well, sir, when we deliberate as to what has become of precision medicine and what is going to happen in India. So I put up 3 faces here: Vivek Subbiah, Ben Westphalen, Razel Kurzrock. 3 giants in precision oncology globally. And then we have our panelists. And what do these guys say? Vivek Subbiah says, tumor agnostic all the way. Ben Westphalen says, let's all MTB. And Razel Ray Kurzrock says, precision will be the cure that cancer needs one day. Opening to my panel here, and we have called them speakers, so please feel free to take it on. What's your thought of that bullet mark? Where do you think we are in precision today? And we can start from that side, from the clinician's perspective, Dr. Prashant Ganeshan. Could we help with a mic?
Yeah, it's a very broad question. So, do you want any specific thing? Where do we?
In general, what do you have in terms of feeling? Do you think there's a lot of work left?
Obviously, in anything, I mean, that's a very general question in oncology, right? Obviously, there's a lot to do. There is a lot to do.
There's a lot to do. Do you think we have arrived anywhere?
So, that's very country specific. So, it's like asking in oncology itself, have we arrived somewhere? Of course, we have. It's not like we have not achieved anything. It depends on what you compare yourself with. So, in oncology in general, we have made huge strides in access, because I would say 10 years back, the amount of people getting access to oncology care was very limited. Now it's much more broad. But are we getting access to all the cutting edge things which are going on? Obviously not. Is our research up to the mark of what is there in the world? Probably not, but again, we have come huge ways. We are producing very high quality research from this country. Maybe baby steps at this point of time, but definitely moving in the right direction. So the same thing applies to precision oncology also. There are now good labs providing high quality reports for us. And there are many labs which are coming up. So the access is increased. So whether the quality is the same of all the labs, that has to improve over a period of time. Just like we talk about pharmaceuticals, the same thing applies to genomic data, genomic labs also. So we are improving from what we were a few years back, but I think we have a long way to go.
Great. This is exactly what I was looking for. That there is hope. As we discuss precision here, it's not all dismal. We are following through. We are coming in line. There is hope. We are working towards a perfection. But hey, I think precision world itself is evolving globally, and we are also chugging along. So when we say precision, we talk about NGS, we talk about other biomarkers, new age biomarkers. There is a global endorsement. There is beginning to happen tumor agnostic approach. There's also molecular tumor board, which is being considered to be pivotal. And of course, the need for equitable and evidence-based implementation. So from this side, Dr. Suruchi Agarwal. Suruchi, we have worked, interacted together for a while, and I appreciate your contribution as a molecular scientist. When you are abreast with patients today, when you are in the open where people are interacting with you for tests, have you seen the pendulum move? Have you seen some changes happen over the years that you've been out there talking to people, interacting, and helping guide people regarding precision medicine? Do you think people are more aware, or are we still very far behind?
Yeah. So in terms of when I talk to the patients, definitely awareness is still lacking. We have to have much more awareness programs for the patient to make them understand what genetics is and how genomics can help actually in their treatment. However, the counselings and, it has to be like a triangle. It has to be like a clinician, genetic counselor, and a geneticist and a lab, and also a pathologist. So that triangle has to be completed, in order to bridge that gap what we see today. So I feel that we are still scratching the surface in terms of genetic testing and in terms of awareness and all. So bridging the gap between clinics and the lab and the counselors would be the way forward.
Great. So I think we are all struggling with the gap. We are all realizing, accepting that there is a huge gap, and we are all, I guess, working towards bridging that gap. As people involved with precision medicine, we are making active strides to try and bridge that gap.
Molecular tumor boards would be one way, but that is also, I feel that that discussion is done in silo and is kind of closed discussion, very much closed discussion. So I feel if it comes out in form of some kind of a database, in form of some kind of case series or those kind of things,
yes,
I think that would be really helpful for the mass to understand what are we doing with the patients using this information.
Great. Thank you. Amol, my question to you as a clinician now. So, there's a picture here, diagnostics and treatment, and it's a perfect match. And then, of course, there's this picture, which just by looking is very intimidating, because you know that there are so many possibilities in each malignancy. But the patient in front of you may or may not be able to do it, may or may not be able to understand the importance of doing it. How do you deal with that challenge?
So I just wanted to have a summary of the 3-4 slides that you have shown before, starting with the concept of that the tissue-based origin or the organ-based origin should be out. And there was a paper in Nature a year back saying that the way forward should be based upon the molecular markers rather than organ of origin. Now, we are not completely reached there because exactly what is shown in this particular slide, because not every particular mutation will be a driver mutation in a particular tumor type. For example, HER2 will be a driver mutation in breast cancer, but may not be that strong driver in a colon cancer or a stomach cancer. So just by mere presence of mutation is not going to have desired results, in fact, equal desired results in all tumor types. Hence, what you have said in the previous slide, that the diagnostics and the treatment matching, that need not be a perfect matching every time, and that is where the role of molecular tumor boards, that is where the role of the oncologist comes into picture. So even though we feel that it is a precision, but that precision is not necessarily precise in everything. For example, if you take NTRK fusions and the anti-NTRK drugs, they were perfectly fine. But that kind of a perfect matching is not seen necessarily in all the mutations and the drugs and the tumor types. So we are still not yet reached to a matching thing. We are still not yet reached at the exact precision. And that is where the molecular tumor boards, that is where the experience of the treating oncologist, all those things come into picture.
Wonderful. Very well said. I think precision itself is not very precise yet. It's a developing science. It is, even though I am a die-hard precision oncologist, I accept this completely. that we haven't really figured out a whole lot yet. Having said that, you see this entourage of drugs that have developed that are all biomarker based. And so I would say it is truly a happy time for medical oncologists as well as for precision oncologists, because you have so many biomarkers to look out for. It is actually intimidating sometimes. You know, you feel you may miss out on something, you may not catch up with the data, you may not be aware what needs to be done, you may not be able to give, and there are so many times even after we find the biomarker, we are not able to give the right drug. I was just, in preparing for this moderation, I was just catching up on how many approvals have happened. Some of them I may have misspelled because I was just trying to get the names from someone's video. And this is not even the last 3 months. Even the last 3 months have seen many more drug approvals, like N-HER2 for HER2 low and ultra low has just happened in the last 3 months. So a lot of Dato-DXd just got approved for FDA approval, just came through. And so many such drugs. It's actually truly a happy time in terms of if you had the playground, you could play around with so many biomarkers and so many drugs. But if you are left with some limitations or large limitations, this is a frustrating time. So that's why now the questions come to two entrepreneurs here. And my question, and I'll ask Ramesh first and then Mr. Santosh. My question here is, as we are going ahead with such elaborate biomarker discovery, how as a leading lab do you stay up to speed with what's going on, and how much do you want to catch up, and how do you deal with the money angle of the need? So I'm asking too many questions in one.
No, that's a good question. So in the last decade, India, labs like us, the environment, the ecosystem of labs in India have sort of done a reasonable job in keeping pace. But I feel that's going to be under threat in the future, and I'll tell you why. When we started, almost a decade back when we started genetic testing in India, EGFR was still happening, single gene tests were happening. But within 2, 3, 4 years of that, panels were there, and then the progression was very rapid right thereafter. And we were able to do that because most of the markers that we're talking about, everything on this slide, were largely single gene. Even though you're doing a panel of 20 genes, 30 genes, 70 genes, 100 genes, whatever, your actions are based on single genes. And single gene measurements are eminently, easier to make, easier to infer, and all of that. So that catch-up has been relatively fast, even though there have been lots of technical challenges, right? Our turnaround times may be lower than Western labs because we need to batch samples, while Western labs have more volumes, they can do it faster and all of that. All of that has changed over time. Turnaround times have come down. The set of panels that we're offering have improved. So it's been slow, steady, reasonably, not too slow, but reasonably steady progress over the last several years. Now, going into the future, which is where I worry, the nature of the biomarker is changing. It's not going to be the single gene biomarker. And oncologists are used to it. If you remember Oncotype DX, that was our earliest sort of precision test, right? Before this wave of things came about. That was not a single gene. That had 21 genes and some complex function of that. And you couldn't trust anybody else to do it because that function only Genomic Health knew. Now we are at the cusp of a wave where the biomarkers are going to become multi-gene again. And when things become multi-gene, you have to run clinical studies to establish within quotes, the AI nature of, what is the combination of those multiple genes that will give an output. And then only the people who have run these large clinical studies, you'll be able to trust only their output. I think we are on the cusp of that going forward. So I think we will have to change our habits, put on different hats, and look at it in the future. I think we've done a reasonable job in the past, but the future is going to hold more challenges there.
Great, great thoughts. We heard molecular tumor board, we heard tumor agnostic, we heard we are catching up clinically in terms of the tests that we are offering our patients. And we heard how we need to evolve from just a single gene. And going back to what Amol said, sometimes even that single gene does not behave the way we expect it to behave in a different context. So context may be important, and context, by saying context, we need to also understand what are the other accompanying genes, like even EGFR. Earlier, when we had the FLORA trial, we had only osimertinib for EGFR exon 19 and 21. And now with FLORA 2, you're supposed to understand what other genes are there along with the EGFR exon 19 and 21. And if there are all these other bad behaving genes, you know, if the EGFR is in bad company, you've got to add more medicines to the drug. So with that, and with the one cue here of the hydras and that cancer is an ever-evolving disease, I come to Mr. Sam Santosh. Thank you for being here today on our panel. My question to you is, you have been there, done that. You've been the founder of MedGenome. You have also been an incubator for many companies. You have mentored the development of genomics and been a pioneer in India. My question to you is, as you see the horizon changing, and in the brief conversation outside, what I heard was, there is hope. My brief conversation with you. And that itself was great. But when I see this slide, and in clinical practice also, this slide is not to scare anyone. It is a reality that we face every day in our clinic. How does one wrap our head around a disease which is ever evolving, and where genomics may just be a small piece of the puzzle, and there may be time now to move ahead into multi-omics, and you may have already moved ahead as a mentor, and I would like to understand that angle from you.
Sure. As the earlier speakers said, I mean, the first wave was looking at when we moved from the standard forms of treatment and went into more personalized or precise approaches in treating cancer. The first wave, what Ramesh was also saying, was trying to find the key genes, right? Key genes, and trying to see what are the targeted drug available for that. And that had a great success. I mean, that is why the first wave of targeted medicine was success. But as you pointed out in the slide, cancer is a much more vicious disease and keeps evolving. So there are a number of ways that things that are happening, fortunately, in what is going to be the future of cancer treatment. So one area that I've been working aggressively is in multi-specific antibodies. So the first wave of antibodies that has been a dramatic weapon in treating cancer still has some limitations. You know, if you go, how many people are with HER2? How many people are with EGFR? You know, and also the challenge of identifying, studying the biology, the earlier slide that you showed. What are these gene mutations doing? So understanding all that, and how does it change from person to person? And then what is the microbiome doing? We know the microbiome is a very important factor in precision medicine, and for for the person to respond to the treatment. But in one way, the multi-specific antibodies are going to be a very significant weapon because the additional mutations that we find need not be the driver mutations. So let us say a patient has 3 or 4 other mutations which are not normal. I mean, that is somewhat related to the cancer, but it may not be driving. But if they are more there in the cancer cells, right, you can use that target as just a guiding guiding one, right? So, because most of the challenge with the antibodies or any drugs are the toxicity. I mean, you may be able to kill the cancer, but you kill other cells. So if there is a second arm or a third arm to the antibody, I mean, you all know the antibody, the Y-shaped antibody, so you can put many arms around the center. So if you put additional arms and use them in this way, so multiple ways. One is to be a beacon, and so hit the cancer cells alone. Second thing will be to add maybe one target is not enough to make it efficacious enough. So you can have the second one to make the treatment more efficacious. So I see a lot of new drugs coming in the next maybe 5-10 years. Unfortunately, many of them will be from China, made in China, then manufactured in the West. So we may be left out unless we get our act together. And the challenge will be in also having the data. So doing as much sequencing as possible of all the samples that you get, and keeping all the data and the samples also safe, so that we will have enough data to know like what are the mutations that are more prevalent in parts of India, because there's going to be, even when I was running MedGenome, we could see the mutations vary significantly across geography. We don't even know why. And even like side of a river, you can see some mutations being much more. So there is a lot of things affecting that. We may not be able to solve all that, but at least with the data, and even if we don't know the fundamental biology, we may be able to make use of that and solve it.
Amazing. So I echo that from my trip to ASCO just a few weeks back, where I felt that the large presence of drug development was actually from China, and we weren't there. You know, I was just regurgitating my clinic data. I was asked to give a presentation, and all I could do was contribute to...
Ma'am, sorry to interrupt in between. A humble request from our side. Everyone who's having the tea, kindly keep your voices low so that the session is not disturbed. Please everyone keep your voices low so that the ongoing session is not disturbed. Thank you.
Thank you. Actually, we are quite loud, so I think we are fine. So yeah, I was just saying that in ASCO, it was completely clear that we weren't there and they were there. So taking a leaf from that and bringing us to, I think I've said it enough that there is, requirement to proceed further from single gene focus into multi-omics, and done a lot of work as a clinician in this area. I'm a big fan of iPredict trial and a local trial that I was involved in, Resilient trial. And multi-omics does give different results, and I actually am currently treating a patient where we had PD-L1, PD-L2 amplification, and this patient did not respond initially to immunotherapy, but to multi-omics treatment. This is a young patient. 3 years ago, the patient was advised best supportive care by an academic center, and with chemo sensitivity, drug sensitivity profiling, and genomics and multi-omics, we've been able to now have a near complete remission for this patient. He was on truckloads of medications for pain control, and the pain is no longer there. He's off of all medicines except for the combination of therapy. This case was also guided by the WIN consortium. So I've taken this case to multiple different molecular tumor boards, and in one such molecular tumor board, then there was guidance given, and I changed the, so I run many molecular tumor boards almost every other day. It's a huddle. I call it a huddle. We do a working meeting. It's not essentially a formalized molecular tumor board. We do with individual companies. We do one with Strand as well, with Datar. I do with WIN Consortium. I do molecular tumor boards. We have run a previous molecular tumor board initiative called Impact India International. I've run the Sloan Kettering molecular tumor boards. I've also run the another local molecular tumor board. And so what I'm trying to say is what Amol just said, I truly stand by that. I think unless and until we sit down and deliberate, the cases are so complicated, the tests are difficult to understand. Unless we bring people together, it will be very difficult. Now, from one sentence that is here, so these slides are actually from Aju. Aju had laid out 4 points for what we should be addressing today. And in that, I have one of the points picked up regarding the current momentum, which includes cost, which includes different types of material that we test, tissue versus liquid, which also includes AI powered insights, and something that is not here, which I believe in a lot, is functional analysis and drug sensitivity. So this is going to be deliberated now as we go ahead. Cost of precision worldwide, and what do people say? So one message from here, what is the cost of not testing? I would like all of us to think about that. Give it a moment. What type of cost do we incur if we don't test in specific conditions where we must be testing? That is what we need to focus on, because enough has been said about whether we test, how can we test, how do we test, etc., etc. So coming to the two clinicians in the room, I would like to pick your brain on this. You know, there are times when even if the patient can test, you have to sit down and really work with them to understand why should they test. Because they went somewhere else, multiple places, and nobody really recommended to test. Have you had such instances?
So I work in a highly resource constrained setting. I work in a government setup. So we do not have a lot of in-house molecular testing. We just do basic panels for lung cancer at this point of time. So if I have to test, I have to send the samples outside. Most of my patients cannot afford it. We have to arrange funding. So the first thing we have to ask the question is, if I find a mutation, is my patient going to afford that therapy for it? If they cannot afford, then I don't test, because there's no point in testing. So I think from my context, the question is very moot, because most of the time the testing is directed by the patient whether they can afford the targeted therapy or not. They cannot, then there's no point going for a huge panel or something like that. So most of the time we go for, if that's going to be a specific question for this drug, I just choose that particular mutation, the cheapest, and then I test only for that. So I don't think I really come across a situation where I want to do a lot of testing and somebody else is, it's probably the other way around. They come to us and say that we've been advised this whole bunch of things and I cannot afford all this, what can I do? And I say that, yeah, you can use all these other options without all these testing and very complex things. So I think we work in a completely different thing. So I know this is a discussion.
So I'll tell you, the insight is very important. Situations in India are very diverse. We absolutely need to understand. Just by presenting the topic, it does not mean that we'll make it happen. You know, no matter where I stand, on this side or that side of precision, doesn't matter. This conversation is regarding being able to make it happen. And so it's very important to understand how the world is operating. And you have brought to light the restrictions, the limitations that are very, very paramount. That's the elephant in the room. No matter how much we deliberate, if we know that we cannot perform the testing, we have to first enable that. So then I would like to ask the next question to you, which will actually help us understand a little more. If that patient comes to you and someone has told him, do the testing, and he doesn't have the money, which door do you knock on? Where do you go? What is a resource that we should all be aware of?
So there are various currently, it's very difficult to get funding for testing from various government schemes. So many of the patients are able to access cancer care because now we have, most of the state governments have insurance funding. The national ABPMJY funding is there. But they do not very actively support testing. Testing is expensive. So that's a limitation. So what we do is some tests we think is very essential, is going to really impact management. That happens for most of the leukemias sometimes. So we tap into, we have our own group of social support people, some local NGOs. We have a WhatsApp group, and we just put into that group that this particular patient needs a test and it's going to cost 10,000 or 15,000, and then we have a lot of people who put in the money, and then we are able to do that test for that person. So that's one way we do it. There are drug companies, based on their products, they subsidize some of the tests. So we make use of that to help them to access that. Sometimes we do that for PARP inhibitors. So for the BRCA testing, we make use of those subsidized coupons. So that's another resource that we tap into. There is something called a Prime Minister National Relief Fund, which I think some of the hospitals can tap into. It's not probably easily accessible for many of the hospitals. So we are government centers, we can tap into that. So that we can use for testing also. So that's a little bit more liberal actually.
But the reality is that that fund may actually become available much later, because it's not available until the patient has a diagnosis. So you have to pre-plan.
Yeah. So you have to pre-plan. The patient comes, you assume that this patient is going to need this down the line. So you start applying for that, assuming that you will do the test 2 months down the line, but you start something else at this point of time. So we pre-plan that, yeah.
Yeah, great. Thank you for the insights. Amol.
So I happen to work on both sides of the system, the government as well as the private, including the corporate section. So I agree with Dr. Ganesh about, Prashant, about what he said about the government sector. So I will try to tell about the other side of the story, that you asked if the patient comes to you with a bunch of tests, what advice I give. So there are very clear-cut guidelines by ASCO as well as ESMO that which are the situations in which we should ask for this test, and which are the situations probably these tests are not that useful, and there is a scoring system given by the ESMO. So I apply that, and if the test is required as per the current evidence, it should be done. And if we explain that to the patient, they of course do it. So our job is to have this balance of use versus abuse, and probably because everything that is available unfortunately gets abused also. So a lot of abuse of precision oncology happens. So as a job of the oncologist is to keep a balance, and there are guidelines clear-cut available, and we have to use them, as well as we have to see the situation of the individual patient. Suppose he has received multiple lines of therapies, he has come to a refractory situation, of course he should be offered genomic testing so as to find out some way forward. So we have, again I will repeat that the precision, if used blindly, can have paradoxical results, and hence it is the person, the oncologist who is using that weapon is the most important person. He has to use it wisely. Otherwise it will have paradoxical results.
Thank you. Thank you. Very well said. I think both clinicians are overlapping in some of the thoughts where there is struggle, there is difficulty utilizing, and then there is
the cost part,
opportunity.
the point you said, the cost is gradually coming down, and I'm happy that so many companies are getting into it. And something I always tell, now Reliance also is getting into making this, and I tell people, look at the internet and look at the SIM card. The moment Reliance is into it, the cost has gone down. So please make sure the cost of the genomic testing also is going to go down. In the next 4 or 5 years, Mukesh Bhai will get all the costs down. So it is good for everybody.
We're going to take this message back.
Yes, please.
Okay. So thank you. Thank you, and thank you for that challenge. We'll have to, stand up to that. So now on the other side of the pendulum, I have a liquid biopsy tracker with Signatera, and you can see there are 3 tests performed for this patient. The patient was offered immunotherapy for stage 3 colorectal cancer. Patient had had a previous treatment with Folfox 10 years ago was left with severe neuropathy. We could not offer, the patient refused to take any further chemo. The patient is Lynch syndrome and MSI high, and this patient then was offered immunotherapy. You may be aware of the atomic data that has just come in with immunotherapy and chemotherapy. This patient, however, refused chemo, was just given immunotherapy, had multiple lymph nodes. Now liquid biopsy tracker was used to see how his ctDNA load was coming down and that he was responding. So question to Ramesh and then to Suruchi. So basically, Ramesh, different types of genomic analysis are today available in regular clinical use, tissue and liquid. Liquid biopsies have now really forayed and become wider in their application, and you are leading one such effort. From early diagnosis to response tracking to treatment escalation to de-escalation, it is informing genomic field in a very wide way. As someone who has led this endeavor in India right from the start, what do you feel regarding the liquid biopsy role, both in early diagnosis as well as in response tracking?
So clearly this is the next, among the several next waves, I think this is clearly the next thing that we have to pay attention to. And we have a very core technical challenge there. I mean, the technical challenge is not often discussed, so I'll put it out. It's you take one tube of blood from a patient, hoping to get insights into either they're a normal person you're screening and you're saying, do they have cancer? Or they're a cancer patient, they've gone through surgery, you want to check whether there's some remaining traces of the tumor still remaining, will the patient be at a high risk for recurrence? So you take one tube, two tubes, let's say, so you get maybe 20 nanograms of DNA. That's all, many people you might only get 10 nanograms, some you might get 30. Those 20 nanograms of DNA will have about 6,000 genome equivalent, 6,000 DNA molecules in there, right? And now tumor presence either at an early detection stage or post-surgery stage is not going to be, it's going to be well less than 1 in 1,000. Maybe it's going to be 1 in 10,000. But you have only 6,000 molecules of DNA in your tube, and you're trying to detect 1 in 10,000. How do you do that, right? So the standard liquid biopsies that are used for treatment selection, where you have a patient, it's clearly a patient, typically the tumor presence in the blood is much higher, it's 1 in 1,000, and that's what we use for treatment selection. Those liquid biopsies will fail in the early detection and MRD settings because you have to go down to 1 in 10,000 and you have only 6,000-7,000 molecules to work with. And there, the solution lies in going broad, that any one place in the genome, if you try to track, because there are only 6,000, the relevant mutation may just not be there. But if you go broad, track lots and lots of places in the genome, or go very personalized, identify that this person had the following mutations in their tumor and track those. So that becomes tumor informed, where you have to do their biopsy or surgery sample first, pick up the right mutations, create a special panel with those and track those. So it's going to lead to a situation where either we have to go very broad or we have to get very, very personalized, meaning for every person create a different panel. So I think the next wave is clearly early detection and minimal residual disease. That will give us a great deal more information into every patient. But we have these technical challenges, and the way these are being solved is looking for biomarkers that are very, very broad, right? So what is a biomarker that's very broad? Mutations are very specific. Methylation signatures are very broad. Thousands of regions across the genome will get affected. So you're able to detect 1 in 10,000 with that. Or by creating, like you showed Signatera, right? What they do is sequence your tumor. Tumor may have thousands of mutations, not necessarily in the genes, could be anywhere, doesn't matter. Now you pick like 16 or 20 or 30 and create a special panel and go very deep, 100,000x measurement, which is very expensive to do, but you do that. So I think we have to fundamentally change the way we think about liquid biopsies to be prepared for this next wave. And we have to be aware of the fact that the same liquid biopsy that we do for treatment selection is not what's going to work for these. And we've got to get the costs of these things down, because these are again going to start at a high cost, like we did with our regular liquid biopsies and solid tumor tests a decade back. And over the next several years, we have to continue to bring them down. So it's going to be one more wave of going up and coming down that we'll see. But clearly, there's going to be a lot of knowledge gained from these, and hopefully it will help. Right?
So, from Prashant to yourself, India and the diversity, so clear, right? Limitation to perform the basic, and then ability to deliver at international level. I think this is what is India. This is how we deal with the diversity. These are the challenges, and I actually feel quite intimidated when I'm faced with, so I work fine in my own cocoon as a private practitioner, but when I come out and I listen to the stories, it is a true challenge, and you all are true heroes, because that's what you're serving. My question now to Mr. Santosh. So you heard the diversity, you heard the challenge. I have a minute and a half. I think we'll go a little bit over time. Yeah, thank you. As someone who has really led this right from the beginning, the evolution that you're seeing right now, and the realization that a lot of the genomic efforts are actually struggling. There is this cost challenge. Tests are so expensive, patients are unable to pay. There's a very bizarre horizon that is happening out there. There are tests coming, there's some undercuts happening to clinicians, there is, tests getting bought, sold. You're in that commercial market. And then there is this need of really bringing the cost down. Do you think it will happen? Will the technology allow that?
Costs will come down, but at the same time, just like what Ramesh was saying, the other challenges are there, right, as we unravel the onion. So the sequencing costs come down, but you have to go more deeper now. So that means, what does that mean? That means you have to sequence more, right? More. So that will bring the costs up. And there is a limit also to how much the sequencing cost per se can come down, right? There's some fundamental basic costs of sample collection, extraction, library preparation. So, so it's very, very difficult to go much down. So not only in testing, in the whole healthcare thing, the costs are going to go tremendously up. There is very little we can do about that.
Do you think there'll ever be a geo for NGS?
No.
No? Vivek Subbiya was once speaking in one of my meetings, and he said 100 rupees.
No.
I'm speaking at an Indian forum, and 100 rupees.
People confuse what you can do in telecommunications or in computers in healthcare. You can't do that.
Coming to you.
So, yeah, maybe you should.
Vivek was close to his prediction. He just said 100 rupees, it should be $100. It will come to $100 for sure.
$100 for sure.
$100 also it would be a great.
$10,000.
Yeah.
So it will come down to $10,000 eventually.
Yeah, very true.
Yes.
Can I just put a
I see
question
some
there?
activity happening now. Yes.
No, it's very, very good that the costs keep coming down. That's why we are able to do some of the tests which we could not even think of 5 years back. So it's good. But at the same time, the mushrooming of genomic companies which are available now out there. So just like in the pharma market, there are so many companies manufacturing. How do we ensure the quality? Is there an effort? At least,
That's a
there are
brilliant
accreditation
point put
and all those
forward.
things. But
how do you know?
How do I know
Yeah.
that this test is reliable?
So that is the whole point that we discussed yesterday also about the pharma companies, that there has to be a governing body
Yes.
which will tell the clinicians and the patients that there is a gradation available, and we have evaluated this company, and it is a grade A plus company or B or C, whatever grade, so that it becomes easier, because there are too many of them, too many of them.
But accreditation and validation data actually is important to understand. So when
But
we go and
Suruchi, we don't understand, right?
No,
Half of the
when-
clinicians,
No,
we
it's-
just don't understand
the
what data
accredita-
you are presenting.
The accreditation is for the lab, but what about the individual tests?
no, it is for individual
Test can be accredited
tests.
too.
There
Each
are-
test has to be accredited, like CAP
Exactly.
accreditation.
Each test is accredited, and there are biannual proficiency testing. Blinded samples are sent to us, and we do blinded tests, and we do ensure that the quality standards are maintained. In addition to that, we have internal audits also going on. So if we have to maintain that accreditation status, the internal audits has to be done periodically and the data shown. Monthly QAD meetings. we
You
have
are
a-
doing it. I'm
Yeah.
not asking about
No, I mean,
Strand or
it's-
MedGenome, but I'm talking about the 20 other companies which are all
Correct.
coming up with these
Yeah,
products.
so
People-
NAB,
People like us, we just remain in that 4-company cocoon. We don't want to move out because you never know what
So
the
there
others
are-
are doing.
You have a website or a site where a clinician or a patient can go, and if I click it, I can see these are the 20 companies accredited and approved.
yeah, so that is so that kind of data, or for each test, your percent positive agreement or negative positive agreement, specificity, sensitivity. So this
the government has to do that. It's a
be
government-
kind of open by the companies.
So, Suruchi, since you have the mic, MTB. I have 3 papers out here from folks in India who have written about MTBs, and there is a meta-analysis that has also been, so there is a lot of buzz around MTBs happening. But, I was the other day asking the Tempus guys, actually really, I was being stubborn with them and saying, if I'm ordering you test, why don't you have an MTB, right? And they couldn't make it happen for me. So I'm just saying that even in the West, and when I led the MSKCC MTB, I realized there was dearth of molecular scientists sitting on that board. When I would run the molecular tumor board, we didn't have assigned people, the clinicians were not talking to the molecular scientists, and the clinicians knew what they were dealing with. But we had all kinds of cases, and we had surprises there, and it was so tough. So, question to you, as a person on this side, opposite of the clinician, do you get requests for MTB? How common are those? Are you able to facilitate them, or there is a void?
Yeah, so I think you are reading my mind. So this has been going on my mind from last maybe 1.5 years since I'm interacting with the clinicians. So basically this is the biggest gap which we see. And as you rightly said, there is a dearth of molecular scientists, and there is a dearth of representation of molecular scientists on molecular tumor boards. So what I feel is, sitting on the other side, is that when we talk about molecular tumor boards, they are hospital molecular tumor boards. And we molecular scientists are often associated with certain companies, with certain labs, who are having some strategic collaboration with those hospitals. So probably we are looked upon as a company representatives, not as a molecular scientist at times. This is one point. The other point is that definitely it's more on the reactive basis, as you said. Yes, clinicians do ask. They would like to have in silo discussions also, like 1-to-1 on 1 reports, that we do on reactive basis, as well as we are trying to come up with a space where we can do it on a proactive basis, because of many reasons. Many clinicians may not have time to go on and to have a formal molecular tumor board, but on the fly, when they are talking to the patient, they just want to pick up a phone and talk to us, like, what happened to this report? Or when we are sending a report out with a a rare finding, we would like to, tell them, like I discussed that ALK case with you, and that
we
patient.
still are supposed to write it up.
And the another lab, I think, had given some bizarre result which was not matching with the clinical presentation at all.
We would have treated that patient completely differently.
Yeah. So that means that these interactions and discussions are helpful. So molecular tumor boards are a platform, a formal platform that can be planned. But I feel that on the fly, proactive discussions has to happen from the molecular scientists as well as from the clinicians, so that a gap has to bridge significantly.
I couldn't agree more on this. Yes, sir.
Seventhi Rakesh Jalali. So, my experience with neuro-oncology, as you know, has been completely transformational. As for the last 5-7 years in particular, as compared to other tumors, not only has its therapeutic and predictive value, but also diagnostic value. So the latest WHO classification, CNS5, incorporates. So our tumor boards used to run for an hour or so, now they are 2.5 hours. And we have a clinical genetist, we have a genetic counselor on board, and we now do Pan-Apollo twice a week from 9:30 to 12, Tuesdays and Fridays. But in order to bring the cost is again a volume game, as has been said. So I also feel that while you retain that leadership of precision oncology and the complexities of multi-omics, we realize the resistance mechanism and liquid biopsies and microenvironment. May I also provocatively say that perhaps at some level we have to find what is called democratization of precision oncology. Democratization of molecular tumor boards. Let us not tell them molecular tumor boards because they are intimidating, and try to glean away the glamour component of it, such that it becomes mainstream. Which tumor board does not have molecular at the moment? And we are lucky that we have a molecular scientist joining online. But in future, in 5 to 10 to 15 years, globally, as well as in many parts of India, the message should be how to make it relatively simple, how to make it relatively accessible, such that there is this intimidating thing does not occur to a mainstream clinician as well as to the patients.
Wonderful thought. Actually, I wanted to come to you to ask how do you, what do you think of precision in brain tumors? And this has been your body of work, and you recognize globally for that. I couldn't agree with you more. And one of the reasons why I moved from one institution to the other 4 years ago was to scale up, to just let it flow, for it to go and be imbibed by 100 centers, 200 centers. Let it just go and become a routine, no longer remain a unique feature that could be with a halo. It shouldn't be that. Unless and until this is incorporated as a routine, we will not be able to see the light truly. So, couldn't agree with you more, sir. And I think the challenge will be to really scale up to that extent, make the tests, and it's never going to be a perfect world. So we have to function in an imperfect time with imperfect tests, with imperfect backing, with limitations that we have, but we are going to have to make it work. So we are completely out of time. I would like to finish with a couple of slides right here. India as a nation, so I borrow this slide from my AACR and UN presentation, where this red bar is all about people who are putting the bill through their personal pockets. And this graph is about the clinical trials, and we saw a whole lot of discussion happening regarding the clinical trials, so that's a beehive. I did not go there. But we know that for 1.5 billion people, 456 trials in 2023 is actually peanuts. So we need to come up with a hub and spoke model, and there may be hundreds of hubs that then collaborate with spokes all across the nation and facilitate not just testing, but therapy with the help of funding and with the help of clinical trials. I don't want to close this without a final word from our godfather here, Advani sir. If we could kindly give a mic to sir. I would just like to hear from him, hear from you, sir. What are your thoughts regarding precision? And without your words, this is not going to be complete.
No, I think there's no question that the precision medicine, molecular analysis have played a major role in the last 10, 15 years, all the development that we have seen. But I think one thing which we should not forget, which I think sometimes we forget, because you get so much engrossed with the molecular thing only that you forget too many things. Remember that the cancer is a multifactorial disease. It's not only in terms of the multiple genes, but multiple factors responsible for it. The multiple ways by which a normal cell is transformed to the cancer cells. And it's epigenetics, we as well know. We know also some diseases where there's no molecular defect and they have been cured with the disease. Look at the acute promyelocytic leukemia, arsenic trioxide, ATRA, they have changed the whole disease from incurable to the curable disease. So I think what I feel is that in all our passion for the precision medicine, we should not forget many other factors whenever we are looking at the patient and not look at one eye. We have to have, God has given us two eyes. So we have to keep our not only eyes, but the brain open to see that we can develop or do something better for our patient.
Amazing. Thank you for that wisdom, and thank you all.